Hello everyone, this is Dr. Naz and today I'll be discussing about coarctation of aorta. Coarctation of aorta is a congenital heart defect characterized by segmental narrowing of the aorta. And aorta is the major blood vessel that supplies oxygenated blood from the heart to the rest of the body. So this narrowing will result in restriction of blood flow and increased pressure in the area above the constriction and decreased blood flow and pressure below the constriction. It affects male twice as often as female, and the most common site is where the ductus arteriosus, also known as ligamentum arteriosum, joins the aorta, which is the isthmus just below the origin of left subclavian artery. So what will happen? There will be increased pressure in the area supplied by left subclavian artery, and there will be decrease in pressure and decreased blood flow in the lower limbs and lower body. The exact cause of coarctation of aorta is unknown. However, the genetic factors and environmental influences may play a role in its development. It is associated with bicuspid aortic valve, perianeurysm of cerebral circulation, patent ductus arteriosus, and Turner syndrome. Remember that the coarctation of aorta is the most common cardiac defect in the patients with Turner syndromes. Coarctation of aorta can be further classified into two main types based on the location of the narrowing in relation to the ductus arteriosus, which is a temporary blood vessel present in the fetal circulation. The preductal coarctation and the postductal coarctation. The preductal coarctation is the narrowing or constriction of the aorta that occurs before the insertion of the ductus arteriosus. It is typically located in the upper part of the aorta near the origin of brachiocephalic artery. Preductal coarctation is usually severe and it presents in early life, a newborn period, or during infancy. Therefore, it is called infantile type of coarctation. The infants with this type of coarctation may have significant symptoms including severe heart failure and poor blood flow to the lower part of the body. The postductal coarctation occurs after the insertion of ductus arteriosus, usually in the descending thoracic aorta distal to the left subclavian artery. It is typically milder and may present later in life, therefore it is also known as adult type, and it can also present in adolescence. Symptoms may be less severe and individuals may have higher blood pressure in the arms compared to the lower body. The common symptoms include hypertension in the upper arms and upper body, but hypotension or low blood pressure and weak pulses in the lower extremities. Therefore, there will be a radiofemoral delay. Femoral pulse is weak and delayed compared to radial pulse. And the patient may also feel fatigue or weakness, especially during physical activity. There may be chest pain or discomfort, headache or dizziness, nose bleeds due to high pressure in the upper body. The systolic murmur can also be best heard over the back. So the investigations include MRI, which is the most accurate investigation, and it will provide a valuable information about the location and severity of the narrowing or constriction. It can also help assess the size and shape of the aorta and other associated abnormalities. The other is chest X-ray. So the chest X-ray may show notching of the ribs, and these are due to collateral vessels, particularly intercostal arteries, to bypass the narrowed segment of the aorta, and they grow to supply the blood to the area below the coarctation. Over time they can cause erosion and notching of the adjacent rib can occur, and it is typically seen in the inferior or lower aspect of the rib, usually between the 5th and 12th ribs, and they can be bilateral or unilateral depending on the severity and extent of the collateral circulation development. The three sign, that is indentation of the aorta at the site of coarctation, dilation before and after the stimulation. So the treatment usually involves surgery, that is surgical decompression of the coarctation or narrowed segment, and it should ideally be performed early in childhood to avoid persistent hypertension. The following techniques can be used, like resection and end-to-end anastomosis, and in cases of severe narrowing or extensive involvement and long segment of aorta, then the patch graft may be used, a synthetic graft can be used, or a segment of the patient's own artery can also be used. So these are the various surgical options. First is resection and end-to-end anastomosis. So we have resected the narrowed portion of the aorta, and the remaining ends have been anastomosed. The second is interposition graft. So the narrowed portion is removed surgically, and then the graft from the patient's own vessel is taken and placed to join the two ends of the aorta. And it is called interposition because this graft is serving as an interposition, creating a new pathway for blood flow and bypassing the narrowed or diseased area. Similarly, the patch angioplasty, where we have applied a patch and a subclavian flap on the other picture. So this picture is showing balloon angioplasty, which is a good alternative to open surgery. So a balloon is inserted using a catheter and a guide wire, and then the balloon is inflated. This inflation will lead to the distension of the narrowed segment, and it will restore the blood supply. So that is the end of the lecture. I hope you learned something from it. If you do, please like my video and subscribe to my YouTube channel. Thank you so much for watching.